Doctor, please introduce yourself to our trio audience.
Yes, thank you. My name is Russell Breisch. I'm a family physician in Philadelphia. I help run a residency program in family medicine, and I see patients about half the week, and I do administrative things about half the week. I specialize in geriatrics and in palliative medicine, but I take care of people of all ages with all problems. The types of visits that we have here, some of them are initial visits, complete physicals, routine health visits, and a great deal of them are follow-up visits for people with chronic problems. People with diabetes, hypertension, heart disease, people who have acute problems, allergies or a sprained ankle, the wide gamut of care that people come to their primary care physician for. Through the day, I'm seeing people on a pace of about every 15 minutes for their routine visits. If it's a new patient or if it's a complete physical, we're budgeted for a half an hour. That half an hour often includes time that the staff has to do certain paperwork things. We have to get the patient in the room and get them ready. And we're always trying to stay on time for our next person. We don't always succeed with that, but we try to keep moving along. So there's always that pressure of the next person who's going to be seen. We try and budget our time so that if things go normally, we have enough time to meet the person's needs, take care of them properly, get it documented properly, and move on to the next person so that we can provide them their care in an efficient fashion, a timely fashion, and a complete fashion all at once.
Now, in that half-hour budget time, as an example, with a new patient, does that also account for time outside of the office visit itself to do the paperwork and document what you found, or is that all part of the half hour?
We ask our new patients to come early to do some of that.
Right.
It usually spills over into the half hour where they are filling out
really
paperwork.
about anything you're doing in terms of recording what you found in their interview.
So I record all the information from the visit while I'm doing the visit. Our office has an electronic health record, and so we do the documentation in real time with the patient. All the electronic health records have checklists of things that you can fill out. It involves some typing and some checkbox kind of structure.
So once that patient leaves, you're essentially finished as far as real-time recording of everything, and you're ready to move into the next office.
90% of my visits, I have closed the chart by the time we leave the room.
Okay.
If there's something very complicated that I have to write a couple of paragraphs about, I finish that off later.
I'm always amazed when I visit my primary care physician that they come in having reviewed enough to come in and at least remember who I was and my background and some of the issues. How possibly in a busy world like you live in do you keep up with that?
You just do. It's
Make
just
it sound simple.
It's just like when you bump into a friend that you haven't seen in 10 years. The stuff that you can remember is interesting. What meal you had when you went out to dinner with them 10 years ago. It's the same kind of thing. You do have your chart as a cue. You can look back and see what you've done. But it is interesting after you spend a couple of visits with somebody. You get to know them and you get to understand the nuances that go on in their life.
Sounds like a lot of pressure given the business and the budgeting that you're forced under the business constraints today. For example, talk about your relationship to this office. Is this your office? Is it a private practice? What is it?
So I, like about half of the family doctors in the area, I'm an employee of a large hospital company. I've worked here for almost 30 years, and I'm given the liberty to practice, for the most part, the way I want. I don't have that much input into business decisions. If we need more paper clips, I have to go and file a requisition, and somebody in Nashville decides whether we need a newer brand of paper clip or not. We also have pressures from the people who pay us to take care of the patients. It's rare for a patient to pay for the service. They pay some copay. But for the most part, the government, if they have Medicare, a private company, if they have private insurance, are paying for the service. And one of the things that's been happening over the past 10 years is the payers want to make sure they're getting their money's worth. We have the most expensive healthcare system in the world, but we don't have the best healthcare system in the world. There's a lot of there's a lot of slop that goes on in terms of waste, in terms of inefficiencies. We still have very high infant mortality rates, for example. Our diabetics don't always have perfect control. The payers have come up with a lot of criteria that we have to look at and match in order to get paid properly. An example is if we are taking care of diabetics, we need to document that the smoking status of 90% of our diabetics. And if we don't document the smoking status of 90% of our diabetics, we don't get paid as well as we could. So there are myriad hoops through which we have to jump to make sure that we get paid properly, our patients get the best care. Most of those hoops make sense. You should know if your diabetic smokes, and you should try and get them to stop. It's not something that's goofy, but it's one more thing that you have to keep touching to make sure that you are hitting that target. So there are a lot of people in the room. There are a lot of payers in the room, whether it's an insurance company, a government, or people's families. There's a lot of people in the room other than just you and the patient.
Interesting way of saying it, and I certainly can appreciate that everybody's trying to enforce best practices by setting these standards from all these different levels, from their view.
Absolutely.
Now, just out of curiosity, if you go back early in those 30 years, were you in private practice then, or were you an employee also then?
I've actually always been an employee.
Okay, so it's slightly different in somebody's running their own business.
That's correct.
You know where we're going because I gave you a preview, but before we go there, let me ask you a slightly different question. A patient who comes into you with some insights, either from their web researching or some advertisement they've seen for a drug or some email they've got saying this drug is better for whatever it is they're being treated for, how much impact does a patient have on you when they raise those kind of questions?
They have some impact. The goal is if I think a treatment is going to be useful for that person. An example is I think that they should be on a cholesterol medicine. And they come in with an advertisement for a specific cholesterol medicine that is reasonable for them to use. I have no problems with that. The research suggests that they're more likely to take it. And the goal is not that I prescribe the right thing, but that they actually use the treatment and do well with that treatment. Part of my job is to educate them on the fact that there may be other things that are equally effective, and one of the people in the room is the person who wrote the formulary for their insurance company, and if the thing they're asking for isn't on the formulary, I have to educate the patient on how that really is going to work. That I can't just say, oh, because of this internet ad, this patient wants it, therefore it's going to get paid for. But for the most part, people who have done that kind of research are a lot of fun to take care of because they want to talk about what's wrong with them, what's going on with them. They don't want me to just pat them on the back, tell them, don't worry about it, honey, here's what you need to do. That kind of patient gets a little boring. And it's a lot of fun to take care of people who take an interest. It sometimes veers off into areas where it's not accurate science. My job is to understand what's out there and understand what is good science versus what isn't such good science, and to help my patients as best I can understand the difference.
I have to say, you're my kind of doctor. I want to be part of the team.
There you go.
And have that conversation. And I've seen with relatives quite different. So I know that's not true for everybody, but I appreciate the approach and the values you bring to that conversation with a patient. So I'm glad we're talking to you.
Thank you.
I described basically what we're thinking about in terms of using a grassroots approach to approach primary care physicians by transplant patients who already have an appointment with the doctor. So they're in there for their normal visit of whatever kind, and they're going to raise the question with their doctor in a prescribed fashion. Very simply, it's a 30-second elevator speech, which basically says, "Doctor, do you talk to your patients about organ donation?" And what I'd like to pose with you today, just to get your candid pro or con, what's the challenge, etc., how would you respond to that? And then talking about the environment you work in, what practical advice could you give us? So let me give you Elizabeth Rubin sitting here in front of you, your good friend, and she asks you,
do you ever talk to your patients about
being an organ donor?
Being an organ and tissue donor.
It's very rare for me to do that. It doesn't come up often. If the person happens to have that on an advance directive document that they're bringing to me, we'll certainly go over that. But it's certainly not something that's in the front of my head when I'm talking to people. I don't have a lot of people who've had transplants in my practice. In my head, I can think of one person who has had a kidney transplant. I actually have two people who have been donors for relatives of kidneys. But if somebody asked me would I be willing to try harder, that would be well received. What I know is that kind of behavior tends to extinguish over a relatively short period of time, that I'll probably spend a week asking people a little more aggressively about being organ donors.
Good point.
And then I'll get back into my routine.
All right, let me interrupt you then, if I may, just to ask you a different question in the middle of this. You're not a youngster just getting out of medical college, but you're not an elder doctor either, okay? What understanding do you have of organ donation as a person? The students coming out of school today, it's been in their classes. I know that for a fact. We speak in front of some of those classes. From your own perspective, what do you know about organ donation? Is it something you'd be able to talk to a patient about in any shape or form?
I believe so. I am, part of my practice is we take care of people in the hospital as well. Mm-hmm. And so some of the mandates from the state in terms of asking everyone whose family member has passed away in the hospital about whether they would be interested in being an organ donor, we're all used to that and aware of that. We have had the people, years ago, the folks from Kidney One or whoever the folks who coordinate transplants in the specific region, they do come out. They do talk to the docs at various institutions. I think intellectually, most of us have an understanding. It's the rare physician who is turned off by the idea, and typically is based on some very strong cultural or religious background that won't change based on a pamphlet, a talk.
Right.
I think most people have had some experience professionally with a person whose life has been saved by a transplant. And most of us really, really think it's a good idea. Again, a good idea and feeling okay talking about it versus I'm going to at each visit because I remember, as opposed to I open up my electronic health record and there's a little box that says it's got a radio button, yes or no on smoking. All right, I got to ask about smoking.
Yeah.
And we check it off.
Right.
It's just not something that people have integrated into what they do on a routine basis.
So if the patient raised that question, and the honest answer is, well, really, no, I don't, except an exceptional case, and they asked you, do you have familiarity with organ donation, and offered you a simple brochure, a trifold brochure, which had the basic facts as something to help you understand it or to be able to refer to it. Our other aspect of this process is to offer Donate Life America type brochures about organ donation to put in the waiting rooms of primary care physicians. Talk to me about, one, would you read that trifold brochure given that you already know enough about it? Or is it one of those things that by the time that patient leaves, they go in the basket, assuming it's unattractive and looks like it would be worth reading, but a busy schedule, not sure. And secondly, what's the challenge in getting a doctor to allow us to put brochures in the waiting area?
Sure. So I definitely think that folks would look at it. Again, we know this is important. This isn't a brochure about how to treat nail fungus. This is an important topic. It's a life-saving topic. And just out of respect to the person who handed it to you, I think most of us are going to look at it carefully.
And they're usually somebody who's had a transplant
Absolutely.
You've got some relationship with, so
Exactly.
They're coming with passion.
And so it's going to be looked at if it adds to my understanding of what the questions would be, that's terrific. If it confirms what I know, that's also terrific. Getting brochures in the waiting room is going to vary from office to office, wherever you go. There will be people who will say, I want nothing in my office. There will be people who say, put up anything you want. You know, you can put up drug ads, you can do whatever you like. We have a rack in our waiting room that contains some educational materials. It may be about community health events that are going on. It may be from the American Cancer Society. It may be a subtle ad from a drug company about something. Ask your doctor about hepatitis C or something like that might be out there. For the most part, we like to have those things channeled through an office manager. And I think most places are going to have a point person who's in charge of making sure the waiting room doesn't look like every leaf off the tree has fallen into the brochure rack, but things for people to look at while the doctor's falling behind, and you can give the patient something to read so that they don't get too mad at us when we're too busy in the back. So there's often a point person, whether it's the office manager, one of the receptionists at the front desk, one of the nurses, who tends to manage that kind of paperwork. And I think in any office that one would go into, trying to figure out who that person is going to be the key to having the materials kept up, so that if the organization sends another box of trifolds that's updated with the newest information, is there somebody who in that office is going to say, oh right, I'm the brochure person, let's make sure some of these transplant brochures get out there. Those are some of the challenges. In a big company like mine, the institution takes some responsibility for making sure that the stuff out there isn't crazy, isn't propaganda for just a sales pitch. And so they do look at that and feel that they have some responsibility to make sure it's something that's reasonable and responsible. In our society, in our country, and certainly in this area, talking about transplant donors is mom and apple pie. Mm-hmm. That we are a culture that is used to hearing about it, and I think the overwhelming majority of folks, at least at one level, think it's a good idea. They may not be willing to do it with their own body, but most people are willing to entertain that possibility. Nobody's going to get offended, grossed out. This is against my religion. I'm leaving your practice and never coming back. That would be unusual.
Yeah.
It's a different topic than some of the things that are more controversial that we provide care.
It's interesting because the basic message that we would be asking a doctor to say to a patient, if they raise the question about organ donation, the patient says, oh yes, I'm an organ donor already. End of message. Okay. Have you told your family? Have you registered with the state? Yes. Okay. If somebody says, no, I really haven't considered it, well, that's scenario number 2. I've got this brochure out in the office you might want to pick up. And by the way, once you make your decision, tell your family, take the action of registering. And then you get somebody who's going to say, nah, I'm not interested in that. And we're not looking for you to get into a logical battle with that person. But
But ideally, when they get the form from the state to re-up their license, maybe when they do that, they'll check off the box.
Yes, that's the idea.
That it may take 2 years from that visit.
Well, you just
confirmed.
You just confirmed what studies have told us. Mm-hmm. The awareness campaign over the past decade has passed, and we are at a stage now where most people are aware. And so now the focus has changed to action. Yep. Every state's got a registry, getting people to take the action of actually doing that. So you're right on. I'm very pleased to hear that you're so tuned into it that you understand that. And
and some of the research has shown that if the doctor tells people stuff, they tend to listen to it. The doctor telling somebody to quit smoking works much better than my front desk handing them a brochure about smoking or seeing a TV commercial. That people, and we've fostered this image, unfortunately, that we're very, very busy. People see that if a doc is really busy and takes the time to actually talk about a topic, that it's probably important. And the compliance rate isn't huge, but it's better than me not telling somebody to quit smoking. It may be better than me not reminding people to check off the box for organ donation.
Just thought about something very different, so let me just ask it. How would the average primary care physician, respond to a patient asking them if they, in fact, are an organ donor, are registered as an organ donor? Would that be too private a question to ask? And where I'm leading to is if the answer is yes, well, then you have testimony to give to a patient saying, I'm an organ donor, I wish you'd consider it.
I think that the response would be varied.
Yeah.
I think that if in fact the doc was a donor, they would almost always say yes. I think if the doc was not an organ donor, they would be less likely to be forthcoming about that. If it was because I was too lazy to check off the box, or if people have very profound personal beliefs that they don't wear on their sleeve but are very important to them, that can be something that's very uncomfortable. We will have patients at the end of life where the family asks us to pray with them. Some people are very comfortable with that. Some people, prayer is not part of their life, and are very uncomfortable with that. So it depends a lot on that person's background. I suspect if the doc had checked off yes on his or her driver's license, which I have, by the way,
Thank you.
that they're probably going to be forthcoming about that. If they haven't, it would be interesting to see how that would go.
Maybe we'd put that as an optional part of the process for the patient to evaluate the doctor they're
There
seeing
you go.
before they ask it, so they're not getting into something they don't want to get into. Any other thoughts or challenges that you can foresee for us as we move ahead with this project?
I think that and I mentioned this a little bit earlier, one of the populations that I think you could utilize if in your grassroots is the voluntary kidney donors, and use them as a doctor. Do you talk to your patients about transplant? That not just the recipients, but the donors.
Yeah.
And because when somebody's had a transplant, we often lose them to the specialist managing the immunosuppressants, whatever organ it is that got transplanted. They tend to see that person more. And yes, they come to us for their flu shot and they do a few things like that. But they live at the nephrologist's office, the cardiologist's office, relatively speaking. The person who's donated a kidney doesn't need to do that anymore. They just come to me and I make sure that everything is okay as I would routinely. And those folks aren't as scary. Their medication list isn't as scary and confusing and, oh my God, what in the heck is this new medicine that I've never heard of? You know, they might have high blood pressure because they're the right age to have high blood pressure, and that's about it. So I think that the primary care doc, if they have patients who are donors, whether it's bone marrow or kidney or whatever the situation is, living donors, might find it that those folks are also in their practice, and hearing from them as well may be a good resource into which you folks could tap.
Great idea, and we certainly would expand our volunteer base coming into the donor families that we have in our networks, and they'd certainly be willing to do that. So that's a great idea. Elizabeth, can you think of anything else you want to ask?
Not really. I think we had talked earlier about the forms that are filled out initially, and would you be willing, do you create those forms?
Sure. So everybody has a form that you fill out when you come to the doctor's office where you list your allergies, you list this, you list that. The one we have is one that we created. People have them that come from Document Central at their institution. It's all over the map. If one has the option, it's all done in the computer, and you add in a box about being an organ donor, I can't imagine anybody objecting to that.
That's interesting.
You know, again, people can leave it blank if they choose not to, and that's fine. That's what's nice about filling out a form.
Yeah.
Is you have the option to just go past that question if you're uncomfortable as a patient answering that. So sure, that's fine. What's interesting for me is because I have to enter all that data into my computer, and I tend to do it while I'm talking to the person. I don't have a Scantron type of form that gets scanned in. I tend to ask the patient directly, maybe reference the form. Some practices, some electronic health records, now have a system it will be the standard soon, where when you have a new appointment with a doctor, you'll go online and you'll fill that out, and it'll dump directly into your electronic health record chart before they show up. Altering a computer program sometimes is very easy, and to put in, are you an organ donor, and the patient can click that, is the kind of thing that you could see people doing.
Yeah.
I think that the filling out the front desk form is getting archaic, and it will continue to move in that direction just as technology advances. About 2014, 2015, all progress notes are going to have to be in some sort of electronic form.
Yeah.
And most of us, once we get over the initial 6-month scariness of putting everything electronically, I could never go back to the manila folder. And so I think that taking advantage of the technology going forward is going to be important. The big players in that, people like GE, some of these other companies that are big in electronic health records, McKesson, there's a couple of them out there that are the big boys in electronic health records. They may be an avenue to tap. Those big companies tend to like to have little foundations that give a little bit of money.
Yeah.
And so to give it in kind by doing a little transplant awareness with their clients who have their electronic health record may be some way to do that, and provide a field that can be searchable. Some of the electronic health records, there's one called Epic that allows users to get a license to do research on the data. And so if somebody who has the authority in a company that owns one of these systems decides to put that in there, it may be an interesting way to do the research. What docs need to know is, does checking off the box on the organ donation work? Does it help? Does me putting it in the computer and then 5 years later when some tragedy ensues and we're standing there having the acute conversation of your loved one is going to die, 5 years ago they checked off the box that said we're going to be an organ donor. One, does that work? Do people listen to it? And if they checked it off, are the families going to say, oh, well, if he checked it off, it's okay? We have that experience with living wills, that if mom wrote something 3 years ago and never talked to the children about it, but we can show it to them in writing, they often go along with it. They usually go along with it, even if it's not what they guessed mom would have said.
Yeah.
If it's in writing, they tend to believe it. And so I think docs will want to see that experience going forward. The primary care docs, the folks who deal with this are the ER docs. They see those folks all the time.
Right.
They typically don't. It doesn't happen in my office, and it's rare in the hospital. In the medical world, in the trauma world, the surgery world, it's going to happen a bit more. Just interesting stuff as I think through it.
Yeah. I can't think of anything else.
Well, Doctor, I thank you very much for taking the time
Thanks,
and
folks.
Virtually being down here in Washington,
There you
D.C.
go.
with us.
There you go. The cherry blossoms look great from here. Absolutely.
Our audience thanks you very much, and you may have helped us launch a successful program across the entire country that would save lives, and we thank you for that.
Thank you very much.
Thank you.
Our audience thanks you very much, and you may have helped us launch a successful program across the entire country that would save lives, and we thank you for that.
Thank you very much.
Thank you.
I think you can recognize that that's one very special doctor. And he gave us his time, and I couldn't imagine how he was getting that time out of his busy schedule. But as we were getting up to leave, I came to understand what had happened. And that was, this was his afternoon off. And he scheduled us for an hour at 1 o'clock in the afternoon. As we get up, he put his jacket on, walked out with us, and told the staff, I'll see you next Monday. This was this Wednesday, by the way.
He was going to a conference, though. He wasn't taking off. He was going to a conference this weekend. If you recall, he was going to come
Okay.
here.
Right.
So he was just taking that up.
But he certainly gave us his free time in support of TRIO. And I think we have a lot of doctors out there who do that. I hope that you glean from that some insights that obviously we're going to build into our programs so that we can be effective, given the understanding now of what a busy schedule they're like. I wouldn't say he's a typical doctor. He's a doctor I'd like to go to, but it does give us those insights, and there's all sorts of ideas there that we are going to incorporate into our program. On that subject, any other quick comments about that? You're going to have more opportunity on that outside of this summit as we go forward, but any other quick questions or comments relative to the PCP, the primary care physician program that we funded for and will launch? Okay, yes, JT.
Yeah, one thing that he said about, the check boxes on the questionnaire about smoking, maybe we can get with DOT and maybe put some pressure on the doctors to have a question, are you an organ donor, in the questionnaire.
That was the suggestion. We had conversation both before and after on this. We did talk to him, for example, about the legalities today of protecting your decision on organ donation, which is something he referenced there toward the end. So, yeah, it's a possibility. There's no central place to do that, though, as you heard, and so that gives you some of the insights, So I do not want to get caught behind the caboose of DOT, HRSA, or UNOS. We're free to do what we want to do, but we get hooked up with them. Man, you guys travel at their pace. We know what that is.
I think we can just go, I'm sorry.
Steve?
One point he brought up in the conversation was with the question, does this help people ultimately make a decision supportive of organ donation if and when a tragedy arises years in the future? And what that brought me back to, I think it was a meeting in St. Louis where the surgeon from LA was talking. Forgot the guy's name. But one of the points he brought up was when it push came to shove and it was a choice for either being a donor or not, said they were able to get close to 90% acceptance at that time. And then just thinking through it, then I was wondering, okay, well, does this help people make that decision? Is getting more names on the list that important?
Truly, we know from studies that it is, okay? And that's why the focus today is get people registered, because the question that is asked, not by a primary care physician, by the way, not even by an ER physician, but the standard of practice is that team, which is led by sort of procurement organizations, specialists who's been trained how to do this, raising the question. And the question, in the case where you're registered, is not really a question. The statement, your loved one has indicated that they want to be an organ donor.
Okay.
Here's how this is going to work. And they seek the cooperation of the family. Without that, and all the OPOs I know of now have access to those registries, so when they go in on a case, they know that information. And they've got a document there to produce in front of the patient, in front of the family rather, and that's why it was important when we're talking about a couple things there. Otherwise, they're saying to the family, would you consider organ donation for your loved one? It's a very tough decision, especially when you got a divided family at that moment in time. So, yes, it's impactful, and that's why if you look at anything that's going on with Donate Life America or the OPOs, it's all pushing for registration on the driver's license because of that.
Thanks for clarifying that.
Merle?
I was just going to say, even if they see it on there and it makes them think about it, anything you can do to plant that seed and just get them thinking about it. It may not have a direct cause and effect that we can measure, but just as you pointed out, we do know that if people have had, it may make somebody go home, I was at the doctor's today and they asked me if I wanted to be an organ donor, and I went in for a cold. Thought that was kind of odd. And people might start talking about it though, and they haven't. Well, it's really, that's a good. I'm an organ donor, and it may, may be impactful in ways that we can't even imagine or measure. But I think doing it's a good thing.
Part of our challenge is going to be come up with some way of measuring the effectiveness of the program. So, give some thoughts to that, and we'll continue with that. Doreen?
I'm going back to what you were saying on the donor registries. I believe it's state by state on whether or not there's a donor registry, and then that becomes actual enforceable when there is a donor registry. Having worked both sides of pre-contract, so to speak, and post, since we do have a donor registry, we found that it is much easier to get successful yeses to donation, because one of the hang-ups is the social a medical information that you have to give, that people don't, you know, they're in a horrible enough space due to the traumatic incidents that's taken place, and then suddenly you're going to have to backtrack to this person's whole life for the medical and social history to make sure that you're giving them a good organ. So when you start with, can you help honor your loved one's wishes, you're more apt to go for a yes. And that's what we found from the information and the research done locally in the Ohio area.
The other thing I would reference for you, Doreen, and I reference this for everybody, you put out a bonus DVD just recently because of the timeliness of it. It wasn't in the sequence that we've already published for the 24 programs we have. So there's number 25 out there today. And that was a presentation just recently by one of the representatives of Donate Life America of the current status of all the states, registries, access to the registries, number of registrations, impact of that, etc. It was an excellent presentation based on facts across the country, and we are at a state now, at a point now, where I forget the exact number, but I think it's above 90% of the states now have a donor registry. And most of them are legally protected of that decision. And secondly, most of them also allow the OPO access to that data so that they can use the data at that point of decision. So go back and look at that DVD if you haven't seen it yet, and continue the education. That's the most current stuff that's available. It's about just a couple months old when that presentation was done. It was fascinating and an excellent presentation. Last chance for any other comments before we move.